Brought to you by Dr. Joe Ordia. Frequently asked questions about neurosurgery and pain management. Questions 76 to 80. Spinal cord stimulation for the treatment of chronic pain. I start with a disclaimer. The opinions expressed here are for general information and based on my own professional experience. They are not intended to replace the advice of your healthcare provider on your particular condition.
Question number 76. What is spinal cord stimulation?
Answer. Spinal cord stimulation is the use of a medical device to deliver controlled electrical impulses to targeted areas of the spinal cord. In our context, the objective would be to provide pain relief.
Question number 77. I recall you mentioned spinal cord stimulation in relation to the gate control theory of pain. Please elaborate on the connection.
Answer. In 1965, Canadian psychologist Ronald Melzack and British anatomist Patrick Wall proposed the gate control theory of pain, which suggested that parts of the spinal cord act like a gatekeeper capable of inhibiting or facilitating the transmission of signals from the body to the brain. The back or dorsal aspect of the spinal cord is the target area. Stimulating the large nerve fibers transmits touch, pressure, and tingling sensations to the brain, and activates inhibitory interneurons to close the gate to pain signals from smaller, slower nerve fibers. The tingling sensation, also referred to as paresthesia, masks the pain. When your foot hurts and you rub it, you feel better because the pain signals are blocked from reaching the brain.
Question number 78. Which patients are suitable candidates for spinal cord stimulation?
Answer. Spinal cord stimulation is not a first-line treatment for pain. It may be considered for patients with chronic neuropathic pain who have failed medical and interventional management. It is mostly beneficial for persistent spinal pain syndrome involving the upper or lower extremity and back, following surgery, painful diabetic neuropathy, and complex regional pain syndrome, CRPS. An individual whose cognitive impairment hinders their ability to provide meaningful feedback during the trial or use the patient remote control may not be suitable. Contraindications to surgery include active infection, bleeding disorder, or uncontrolled diabetes. An MRI or CT scan of the spine is obtained to identify abnormalities that might interfere with the precise placement of the epidural lead. Psychological screening is required because managing the psychological stress caused by chronic pain maximizes the benefits of spinal cord stimulation. A patient with a cardiac pacemaker should consider a spinal cord stimulator from the same manufacturer, if available, for easier access to technical support.
Question number 79. If the MRI is good, and psychological clearance has been given, what is the next step?
Answer. The next step is a trial phase to assess the effectiveness of the therapy before deciding on permanent implantation. The patient should receive a thorough explanation of the potential risks and their questions clearly answered. The percutaneous technique is often used. The percutaneous lead is composed of wires insulated with polyurethane and featuring an array of cylindrical electrodes typically made of platinum iridium, titanium, or gold at the distal end. A connector at the proximal end connects to the generator. The trial can be done with a single or dual leads. Under mild sedation and local anesthesia, a special spinal needle is passed into the appropriate level of the spine, and using fluoroscopic image guidance, the lead is advanced into the epidural space. Dual leads are placed parallel, one on each side of the midline. The connectors are attached to a handheld trial stimulator via a trial cable. Intraoperative stimulation testing involves using various electrode combinations. Patient feedback helps to fine-tune the optimal placement. The goal is paresthesia, covering the affected areas of pain. The cable is discarded. The proximal ends of the leads are secured to the skin, a sterile dressing is applied, and the leads are connected to a trial stimulator. A paddle lead trial might be an option if spinal abnormalities present challenges for percutaneous lead placement. Unlike the thin cylindrical percutaneous lead, the distal end of the paddle lead is flat and is usually made of silicone. The array of electrodes are only on one surface. The placement of the paddle lead is more invasive and requires a back incision and a laminotomy, which can also be done under sedation and local anesthesia. A temporary paddle trial is otherwise similar to a percutaneous trial. After direct epidural lead placement under fluoroscopy and satisfactory testing, the proximal lead wires are externalized, secured, and a dressing is placed. A drawback is that, following the trial, the lead has to be removed in the operating room. With a permanent paddle trial, the epidural lead is fully implanted and anchored. It is connected to a lead extension, which is the only part that is externalized and connected to a trial stimulator. If later proceeding with a permanent implant, the extension is discarded and the existing lead is connected to an implantable pulse generator, IPG. In the recovery room, a company representative will add several programs to the stimulator and teach the patient how to use the remote control. Many patients like low-frequency tonic stimulation, which masks the pain with paresthesia during the day. The high-frequency HF mode is favored by some at night, as it targets inhibitory interneurons to alleviate pain while avoiding the large dorsal column nerves, ensuring pain relief without paresthesia. Percutaneous trial is usually day surgery, while those who undergo a laminotomy may be observed overnight. The length of the trial is variable, but commonly around 3 to 7 days. Pain reduction of at least 50% is considered to be a successful response. Percutaneous leads are pulled out at the office. A temporary paddle trial requires surgery for removal. With a permanent paddle trial, the extension is removed in the operating room, and if the trial was successful, the pulse generator can be implanted simultaneously.
Question number 80. What does permanent implantation involve?
Answer. If the trial is successful, permanent implantation is done under mild sedation and local anesthesia. To implant percutaneous leads, an incision is made in the back, a spinal needle is introduced, and under fluoroscopy, the epidural leads are advanced to mirror their positions during the trial. Test stimulation is performed to confirm that paresthesia covers the painful areas. The lead wires are anchored to the ligament or fascia, and lead extensions are added if more length is needed. They are tunneled under the skin to a second incision and subcutaneous pocket in the upper buttock chest or abdominal wall, and connected to the generator, which is about the size of a pacemaker. Impedances are measured to ensure proper connections between the leads and the generator. The generator is placed in the pocket, and both incisions are closed and dressings are applied. The generator typically contains a battery and a computer chip enclosed in a titanium or plastic case. A rechargeable generator with lithium-ion battery has a lifespan of 10 years or longer. A non-rechargeable model with lithium battery lasts around 5 years, however, with light use or low energy burst stimulation, some may last up to 10 years. Following a temporary paddle trial, the previous spinal incision is reopened, and a new paddle lead is advanced into the epidural space under fluoroscopy. After satisfactory test stimulation, the lead wires are anchored to the fascia or ligament. Lead extensions may be added before they are tunneled to a subcutaneous pocket and connected to the generator, and impedances are verified. The generator is placed in the pocket, the wounds are closed, and dressings are applied. The surgery is similar if the trial was with a permanent paddle. However, the externalized extension is discarded, and the existing paddle wires, with or without new extensions, are tunneled to the pocket and connected to the generator. Impedances are checked, wounds are closed, and dressings are applied. Prior to discharge, the patient is taught how to use the remote control. Charging guidelines are included if the generator is rechargeable. Further reprogramming may be done during follow-up office visits. Reaching overhead, bending, twisting, and heavy lifting should be avoided for several weeks to prevent displacement of the lead. Please remember these safety tips. Always have the remote control readily available. Turn off the stimulator while driving or operating machinery to avoid distraction from the stimulation. Airport and security metal detectors can trigger the generator, so opt for a manual screening. Be prepared to show an identification card, ID, which you will receive from the manufacturer with information about your devices. Inform your healthcare provider about the stimulator before scheduling any MRI scan, as specific safety conditions have to be followed. Your surgeon should use bipolar electrocautery during surgery instead of monopolar.